Screening. This is kind of what we're here to talk about tonight, and there is some controversy. I know that in the last several months there was some recommendations by the panels in Washington. Usually those panels are out of touch like they are with everything else in the country at this point in time. But the recommendations have been controversial, and that's because some folks think that we overtreat prostate cancer. And certainly my goal as a urologist is not to overtreat it. It's not to undertreat it. It's to treat the people who need treatment and treat them appropriately. The AUA, which is the American Urological Association, it's the governing body behind all urologists, as well as the American Cancer Society, have published some recommendations. The main recommendation that I think everyone should take home tonight is that when you decide if you're going to be screened for prostate cancer, you need to know the information. You need to understand what it means to be screened, what the risks are of being screened, as well as what's going to happen if you're screened and you're positive, as well as what's going to happen if you're screened and you're negative. So I think that the most important thing I want to talk to you tonight about is, again, arming yourself with the information to be able to make the personal decision if do you want to be screened or not. There are consequences to either side of that coin, whichever way you choose. The general guidelines have been historically that all men above the age of 50 should have a baseline rectal exam as well as the simple blood test, the PSA. Men with a family history, as we alluded to earlier, who do have a significantly higher risk of getting prostate cancer, the recommendation is actually that you start at the age of 40. In most cases, this is an annual exam, as you may know. In some instances, if you're very low risk, we may do it every other year, every 5 years. But it's certainly recommended that you get at least an initial screening test to determine where you are in the gamut of your overall risk profile. So 2 large trials were conducted, and this is kind of why the panel in Washington made the recommendation. There was a European trial, which I hate to say that in this circumstance, a European trial actually was a lot better than the American trial. And the reason why was because less men had been screened in Europe compared to those in America. And so when you put together a study and try to get a real idea of what the risk is, then if you have a group of men who have already been screened and then you put them into a group and declare them as an unscreened group, which is kind of what happened in the American trial, you don't really get the best evidence that you're looking for. Unlike the European trial, which actually had a lot truer numbers and were able to differentiate truly unscreened men from screened men, and then they came up with their statistics to show that there was a significant reduction, actually around a 20% reduction in cancer mortality from the screened group as compared to the non-screened group. The one thing that we did learn, which I think most urologists have known for some time is, and the general public knows this as well, is that generally prostate cancer is not a disease that's going to kill you today or tomorrow. Right? It's not going to be one of those quick ones where the doctor says you have 6 months to live. In general, the effects of prostate cancer are going to go out to around the 10-year mark. So once you're diagnosed with prostate cancer, depending where you are on the level of your disease, most men will usually have at least 5 years, if not 10 years, before they're going to suffer any significant life-threatening consequences of the disease. So, chemoprevention. Chemoprevention means, is there any way that we can stop or prevent prostate cancer from coming up? That would be the ideal situation, is that if we could just stop the disease before it even started by giving medications or giving vitamin supplements and things like that. And there have been some good studies to look at this. The prostate cancer prevention trial was a large trial, nearly 20,000 men, and I don't know if any of you have ever heard of the medications on the advertisements and such, but there's a medication called Proscar as well as Avodart, and these are medications that are used typically to treat enlarged prostates. And I do want to differentiate that there is a difference between an enlarged prostate and a cancerous prostate. Okay, so the medication FINASTERIDE or Proscar was used in this particular trial. We know that what this medication does is shrinks the prostate by 25%, and so that's oftentimes why we use it to help with urinary symptoms in men. But part of the time when we were using this medication to shrink the prostate, we also started seeing that there seemed to be a reduction in the number of prostate cancers that were showing up. So some smart man decided that they would put together a trial and determine, was this actually true or not? Well, it turns out that there was actually a reduction in the amount of prostate cancer that was diagnosed. About 25% reduction, actually. The one concerning finding that really kept this medication from being marketed or FDA approved to be an actual chemo prevention medication was an odd statistic that showed that there was some increase in higher grade, so more advanced appearing cancers in the FINASTERIDE group as compared to the people who just got the sugar pill, the placebo. When we went back and looked at this in follow-up studies, we actually showed that statistic may not be true or not. However, as things go in Washington, when these things happen, there's always a big concern, and until further evidence has been examined, at this point in time, there's still no evidence or no recommendation to use this particular medication for chemoprevention. You see here in this slide that of the finasteride group, in the follow-up study, only 6% compared to 8% of the men actually did have higher grade cancer. But that was a concern, and that's a concern to me, that if I give someone a medication, I don't want them to have a higher grade of disease or a more aggressive disease because of that medication. Selenium and vitamin E. These are commonly known vitamins, supplements that people will take. A lot of men take vitamin E. I know my grandfather took vitamin E in quite a large dose. He kind of swore by it as if it were something good. It does have its very good qualities. People thought that maybe it would also be used to prevent prostate cancer. So another trial was done, just like we do in medicine, to try to figure out, is this true or is this not true? We looked at giving people selenium and a water pill or a sugar pill, vitamin E and a sugar pill, a combination of selenium and vitamin E, and then just having the sugar pill itself. And we thought, well, we'll see if this actually does give any prevention to prostate cancer over the course of years. So over 35,000 patients were involved in this study, so it's a good study based on the number itself. But unfortunately, we found that there was no effect on reduction of prostate cancer diagnosis from either the drug alone or combination of those two medications. The reduced trial, again, this is the trial that was the same one as the PCPT trial, which was we talked about earlier, except this one used Avodart, which I think is probably the most commonly advertised medication in this category at this point in time. Again, just like the other medication, there was a reduction of prostate cancer diagnosis, about 23 to 25%. But again, there was some increase in risk of having a higher grade cancer. So kind of the conclusion on that whole story is that right now there's no FDA indication for prevention with using either one of these medications. And the reasonable concern is that we may be making more aggressive cancers appear. Whether that's true or not true, that still has to be weighed out and then studied over the next couple of years. Hopefully we will get something, though, that we can use to prevent prostate cancer.